You are listening to the Movement Therapy Podcast.
Hello everyone and welcome back to another episode of the Movement Therapy Podcast. Zoe, the main thing today is
The new
new
setup.
chairs. What do you think?
I love it.
It's good. It's
I'm
comfy, more
Liking it.
relaxed.
We're getting there.
Yeah, I think we're progressing. We've got a shoulder model, which is not what we're talking about today. So
That's
it's
all
good that
right.
we've got one of those in there.
It's part of the body, and the body's all connected.
Exactly. It is all connected. So last couple of sessions on the knee, we've talked about the anatomy, physiology. We've gone through the different ligaments, the muscles, how everything moves. We've
Yep.
talked about the ACL and the PCL and their sort of locking mechanism when walking and
Yep.
how that's all important. So that's our first episode of the knee. Then we've had two pretty good episodes with Dr. Cross.
How good was that?
Yeah, it was a
That
big couple of sessions, which was awesome.
It was. Learned a lot. It was very interesting.
Yeah. So that's, we'll talk about it a little bit more later, but that's his bracing protocol for non-surgical ACL repair and all his research about that.
So what are we talking about today, Eve?
So today we're going to wrap up the knee joint, specifically the ACL part of the knee. So we're going to talk about the rehabilitation protocol essentially and what to expect coming into the physio, what we will take you through in terms of the journey, what you expect to find, as well as some of the common sort of myths about the rehab phase and returning to sport.
Yeah, great.
But we'll also do some stats. think,
I
as
love
well,
a good
'cause
stat.
we can't go an episode without a stat.
I've done some digging for some stats
Great.
for you. So, well, let's get into today then.
Yes, let's get into today. So I think the main start is how to do an ACL, or how does one?
So how does
Right.
one do an ACL?
Yes.
It's not a how-to
It's not a
guide. We don't want
how-to.
anyone to go and do an ACL. But
This is not an instructional video.
if it was going to happen, this is how you would
This
do
is how
it.
to do it. Yeah, typically for an ACL tear, you have to have some compression
Yep.
or some loading.
Yep.
So normally that is a planted foot on the ground.
Yeah.
And then there's either some twisting, some knee hyperextension, and the main thing is that it's multifactorial. So there's a few different directions going in at the same time.
Yeah. Something has to happen somewhere else to cause the ACL to tear. It doesn't just
multiple
spontaneously
things. Yeah.
happen by itself.
Yeah, exactly. So it's a very, very thick and strong ligament in the body. And normally, where we can see strains of the ACL, it's not common.
Yeah.
So like you would strain, a grade 1 of your ankle ligaments.
Yeah.
It's unlikely to do a minor strain of the ACL. You're much more likely to rupture it purely because if you're going to put enough force to strain it, normally you put
It'll
enough force
tear.
to tear. Yeah.
Right.
So you're going to have compression, a twist, and you're going to have, normally when that happens is you're going to feel hear a pop.
Yeah.
That's a really interesting word when we always ask, did you hear a pop? If you say crack or break or something, we're not interested.
Yeah.
Pop specifically. And if you ever heard an ACL tear, it actually does sound like a pop. It's a
the
very
alarm bells
strange...
start going off. Someone
Yeah,
comes
if anyone
in with
says
pop.
pop, you're already in trouble. So that's sort of number one. We're going to ask you, what happened? Did you twist your knee while your foot was planted? If that's sort of, yes, okay, the mechanism's there. Did you hear a pop? Yes, okay, mechanism's there. And then what we're looking for is the swelling of the knee. Now, normal structures, if you roll an ankle, the ankle swells up straight away.
It
It's the
does,
size of
yeah.
a basketball by the time you've come off the ground.
Yeah.
With a knee, specifically the ACL, it doesn't swell straight away.
Right.
So it usually takes a few hours, if not the next day, until it actually starts swelling.
Right.
So a lot of people, when they do their ACL and only their ACL, which can incidentally be pain-free
Yes.
when you completely tear it
Yeah.
and injure nothing else, often they'll find if they don't have a proper sports trainer or physio on the sideline, they'll go back out on the field.
Yeah.
Because there's no swelling, there's very little pain, there's normally just the sort of shock associated with
Yeah.
the pop, and then there's the initial sort of freak out, and then that passes, and the player often thinks they can go back out into the field. And then what happens is they try to
Change direction.
fall
Fall over.
and just fall over because their knee and their brain doesn't want their knee to be used. So
Yeah.
it'll block that by essentially
Right.
collapsing. So that's the main sort of mechanism
Yeah.
for an ACL. It's that the twist, the word twist is so important. You've got to have that twisting mechanism while the knee shifts forward or backwards. So that's the main two.
A twist and a
Um,
pop.
Yeah, we often find it as well when people are decelerating or accelerating.
Yeah.
That includes like change of direction
Yeah.
and twisting. So normally if you're going one direction and you turn, there'll be a deceleration component to
Yeah.
it. And that often is enough to shift the tibia on the femur,
Yeah.
which produces enough force in the ACL anyway. Plus a change of direction, you add the twist, there's your pop.
Yeah.
So typically with sort of the main demographic we're seeing ACL tears in and population is the team sports.
Yes.
So we've got your soccer, your AFL, not so much netball.
Really?
And I don't know exactly why, but
That's
there's
surprising.
one reason that the foot doesn't plant, it slides.
Yeah.
Obviously there's exceptions, but...
In my non-clinical life, I've seen a lot of netball ACLs.
Have you?
I have.
Excellent.
Not personally, thank goodness.
Yeah,
but
good.
Yeah,
Yeah.
it's
And it definitely, happens absolutely. Basketball as well, the same.
Yeah.
Just with the team sports and the footy sports, because you have studs and
Yes.
cleats, it's much easier to plant your foot in the
Yeah.
ground and much more rigid so that the knee then has to twist. Whereas
Yeah.
you can slide more easily on those court sports, but definitely, heavy impact for netballers
Yeah.
and hockey and,
So I know we mentioned briefly the different types of contact,
Yep.
but let's jump into that.
Yeah,
so
sure.
you mentioned the direct contact,
Yeah,
I
so
think?
if we just talk about those team sports,
Yep.
let's talk AFL, rugby, touch, OzTag, these sort of sports where there's a lot of people on the field in a small area and usually there's tackling involved or
Yeah.
even just by mistake. Even a non-contact sport like soccer, which
Yep.
I class as a contact sport anyway. There seems
yeah,
to be
I
a lot
would.
these
Yeah,
days. But direct contact is, as the name suggests, essentially someone directly hitting your knee.
Yeah.
And really, a lot of that time, it's just bad luck.
Yeah.
You can't predict what someone else is doing on the field. It's really not that controllable by you, and it's sort of unlucky. So
Yep.
it sort of fits between our 10 to 15% of population
Yeah.
of ACL tests. So not super high, but it does happen.
Yeah.
I like treating those people because
Oh,
it
really?
usually means there's no biomechanical deficit to
Yeah,
the tear.
okay.
We'll talk about that in our non-contacts, but they're a good population. Normally, it's just unlucky.
Bad luck.
Yeah. But then you can have an indirect contact.
Uh-huh.
So this is where we get a little bit, I guess when we're doing the movement assessment, we have to take this into consideration as to they might have a movement deficit, but also they were influenced in the air or something. So normally an indirect contact is when a player is disrupted in the movement that they're trying to do.
Okay.
So if you take AFL, for example,
Yeah.
a ruckman, like yourself.
Like myself.
So
Ruckman. Yeah.
Ruckwoman?
Ruck.
Ruck. There you go. So if you take a ruck
Yeah.
and they're jumping,
Yes.
and if they get bumped in the air by another ruck
Yeah.
and then land,
Yeah, there's been a few times I've landed and it's felt a bit weird.
Yeah.
Luckily, everything's stayed attached, but yeah, I can
Yes.
definitely see how something can...
so it's in your head, you're planning a movement already,
Yes.
and then someone disrupts that movement. You might not have time to replan a new movement pattern.
Yeah, I think, and also, I guess in your brain, you've planned out what's going to happen and how you're going to land, and you're not
Yep.
always accounting for an external blow to any part of your body.
Yeah. So unlike sports that you can control, or even training where you're in control a lot more,
Yeah.
unless you're doing a game simulation or a drill and that sort of stuff, you are not in control of the opposition.
Yes.
Or even your own teammates in that setting. And so that indirect contact we see quite often as a reason for that ACL tear, just because it's a new motor program that you have to learn really quickly. So we often find that that's not necessarily a motor programming problem, but just a execution problem.
Right, yeah.
Or a speed of execution problem. So
Yeah.
they might be a little bit slow in that area. And so that's what we can progress
Yeah.
in the full rehab.
And
for
then
that.
finally, the non-contact.
This is the most of what we see in
Yeah.
the clinic is our non-contact. And it's often, whoever has had a non-contact ACL injury, they will describe it as, I'm that guy just at the back of the field who's trying to turn left and suddenly I'm on the ground. And they have no idea why it's happened.
Yeah.
And suddenly they're just trying to run. They're not even sprinting. They're just
No.
turning a corner and suddenly their ACL has popped.
Yeah.
So it's such a weird thing because I described earlier how much force you need to actually rupture an ACL.
Yeah.
And then we talk about the non-contact ACL injuries that in theory don't need a lot of force through it.
Yeah, well, I guess when you think back to our running episodes and we talked about how much force goes through your leg every single stride that you take,
Yeah.
you don't think that there's a lot going through your leg, but then just at, first glance, you don't think there's a lot going through your leg
Yeah.
when you're just running by yourself.
Exactly.
But yeah, I can't remember what number it was, but it was a large
Yeah, it's heaps.
amount of force that just every step
Yeah.
goes through you.
And this is exactly where it's not just that, but it's the accumulation of the load
Yeah.
from how you're moving. So we are really interested in our non-contact injuries after the ACL is healed.
Yeah.
So we take them through the 12 months of their healing cycle, which we talk about. But then it's after that I'm really excited to look
Yeah.
at how they move, why they actually did the ACL in the first place. That's the important part from a non-contact ACL injury, because there's often heaps we can do to prevent something else from happening or reduce the risk of something else happening.
Yeah.
Hopefully, the other ACL or the re-rupture of a grafting tear or something.
Yeah. Well, speaking of a re-rupture and all of these incidences of tears, I've got some stats for you if you'd like.
I mean, I know I think in Australia from researching this, about 80% of ACL tears are non-contact.
Yeah.
What are some other male-female differences, ACL tears?
Yeah. I had a look. I did some digging around
Yeah.
and I found that ACL injuries, it's in Australia, we have one of the highest rates of ACL reconstructions.
So the
in all
actual
countries.
surgery.
The actual surgery. And
Yeah, interesting.
the injuries the fastest annual growth rate of all knee injuries. So it goes up by 5.2% for men and 6.2% for women yearly.
So I would have assumed that that's just from a women point of view, that there's more women in sport now, which is great.
Yeah.
But the men progressing that high is interesting
Men
as well.
progressing as well was interesting. I think also I had a look into AFL a bit more, just
Yeah.
from a...
I think that's a big cohort of what we see.
Yes, yeah. As a woman, you're also 3 to 7 times more likely to injure an ACL playing AFL than any other sport. And there's a few speculative reasons for that at the moment.
Nothing proven yet.
No, I think because there's not enough data and
Yep.
it's nothing longitudinal, so it's nothing
Yep.
long term, you can't really make a definitive conclusion from it. But it's a lot of, you're newer to the sport. Men have been commonly playing AFL for a lot longer than women. And so it's newer movement patterns and that sort of thing as well, like less refined skills. And also women have a shorter season than men. So not always at the sub-elite, your recreational level, but at the elite level, their seasons are a lot shorter and their games are a lot closer together. AFLW has about a 6 times higher ACL injury rate than the AFL.
Wow.
But on a positive note, it's decreased in 2023, the rate,
Good.
2.51 injuries per 1,000 player hours.
Cool.
So
Yeah, so that's really good. I think as well that, and I'm sure we'll do an episode on this, but managing the female athlete through the menstrual cycle, I think is
Yes.
a huge one that is not really undertaken currently.
yeah,
There's a lot of holes in the research for that.
Yeah, I think there's an obvious research gap in injuries in women's sports specifically. Just I think there hasn't been as many elite competitions.
Yeah, true. It's becoming way more popular now.
Yeah.
Which is great, but I think we need that research at some point to come out and actually give us some protocols as to how we train the female athlete and what is the training cycle looks like with relation to the menstrual cycle and potential injury risk.
Yeah. Anyway, because we could be here all day.
We could be. Well, that's going to be another episode, I hope. So, yes, let's move on.
We'll move on. But another thing that you mentioned before is risk factors for tearing your ACL.
Yes.
One that I found was the dorsiflexions of the ankles, so bending the foot up towards the shin. And I was reading a study that found that when you had a greater range of motion with ankle dorsiflexion, so being able to bend
So that is just bringing your foot back towards your shin.
Yes.
Yeah.
It was associated with greater knee flexion displacement. So that movement that you talked about before in the knee, so it's the amount of movement or shift in the knee joint when it's bent.
Yep.
It also was associated with less ground force reaction. So as we talked about, force when you take a step.
Through the foot.
Through the foot.
Yeah.
So all of those combined, the greater range of motion in the ankle, the movement in the knee joint, and then also the ground force, it leads to a better landing position.
Yep.
So with that landing position, it actually made people less likely to tear their ACL.
Yeah, cool.
So
There's definitely been more, I think, anecdotally in the actual clinic when we're seeing clients coming through with ACL tears, not just to look at the knee, but then figure out what's happening at the hip, what's happening at the ankle, what's happening at the spine, because when they finish their rehab, that's when we go into the non-contact
Yeah.
zone and say, well, did you do this because your dorsiflexion is 10 degrees less on the right than on the left?
Yeah, I mean, as you said, the whole body's connected.
Exactly.
So it's not just going to be what's happening in the knee, it's going to be happening around it as well. But then also another thing that I found was about knee proprioception. So knowing where the knee kind of is in space. Cool. So I guess as we're sitting here, you know, if you were to close your eyes, you would know where your foot is.
Yep.
So there's a study of about 30 male athletes,
Yep.
and they compared their dominant and non-dominant knees when they placed their leg in a commonly found position to tear your ACL.
Sure. Yep.
They found that on their non-dominant leg, they were not as sure of where their knee was in space. So they weren't, I guess, theoretically then able to control it as well.
Yeah.
So they're more likely to tear their ACL when you don't really know where your knee is in space.
Yep. And this is one, I guess, for the juniors out there who their coach keeps ragging on them for trying to do left foot kicking and things. Must always do things with your left side because you don't want to have massive deficit with that left side versus the right.
Yeah, I think doing all of the proprioception and balance and just kind of your functional movement things is something that we sometimes forget because I'm not just kicking goals and a dead straight ball over and over and over and over. It's it's the building blocks for that sort of thing.
Yeah,
because
exactly.
I can kick a ball, that's great, but can I kick the ball the same way if someone's coming through and knocking me over at the same time?
And that's with winter sport, with any sort of sport, it's unpredictable.
Yeah.
So you're not always going to run left, right, straight, on the next Saturday. It's going to be completely different. So you can't necessarily plan for what you're actually doing on the field. There's a little bit of that.
Yeah.
Excellent. So that's really interesting stats with that. I think it should hone in on the fact that ACL is a massive problem in Australia.
Yes, yeah.
More so than any other else,
yeah, and
place
I
in the
think
world.
it also shows how it's across all age groups. It's not just, 19 to 25-year-old males who play sport. It's
exactly.
You can tear your ACL skiing. Your stepmom can be on a holiday in a retirement and she'll come back.
I had one
skiing.
the other day, someone trying to load their air conditioner into a truck and stepped down and twisted and landed, did it. So you don't have to be playing sport.
No.
Teachers, it's somewhat common for them if they're going out with the older students on the field and just
having fun.
having a quick little game of touch, footy or something. And
showing
then
off.
That's a common one. I've treated a couple of young teachers for that. So you don't have to be an athlete, sport, it could be anything.
Can be anything,
Yeah, it's one of those.
So now you've torn your ACL. Then we've got the different types of recovery pathways.
Sure.
So we've talked about Dr. Cross already.
Yes, so go back and listen to those couple episodes because that gives you a really clear indication of a potential treatment protocol that's non-surgical, it involves a brace, and it actually encourages healing of your own ACL.
Yeah.
So that's one protocol that you can go through.
It's super interesting. I love
it's amazing
learning
research.
more about it. It's just,
And hopefully it becomes more common and then they can actually do it to more varied types of tears.
Yes.
It's a really, really good protocol.
Yeah.
I guess the next two would either go surgery, non-surgery.
Yes.
So this is the discussion we have pretty early in the clinic because a lot of people are scared of rupturing their ACL, which is warranted. It is a very... it's probably one of the longest rehabbed ligaments, that and the Achilles, which is a tendon.
And I think when you are around people, I personally have been around a lot of people who've torn ACLs once or more, and you see the strain that it puts on people physically and mentally, and you pretty much just see the 12 months.
Exactly. It's so well documented in literature at the moment, and anecdotally people talk about it. They know he's done an ACL. In the media, that's bad.
Yes.
It's a negative connotation. It's, I'm out for 12 months. Will I ever get back? It's those sort of things. So there's a lot of fear around ACL injuries, which is absolutely warranted. So I think from our conversation when we see you in the clinic, it's going, take some time, take a week, take a couple of days, have a chat to your family, have a chat to your friends, and figure out what pathway you want to go to.
Yeah.
And it doesn't have to be the same pathway the entire time.
Yeah.
So it's super variable. And I've had a lot of people change and try the non-surgical and then jump back over to surgical, which is completely fine.
Yeah. And I think as Dr. Cross mentioned as well, it's not, unfortunately, for everyone.
Exactly.
It's only going to work if it works.
Yeah, 100%. So I think for surgery, we'll talk about that quickly, and then we'll get on to our non-surgical. So Surgery, obviously they take a graft normally from the hamstring,
Yeah.
but they can take from the patella and they can take from the ITB or sort of any other sort of ligamentous tissue that they warrant or feel is strong enough.
Yes.
And then they essentially drill a hole through the tibia and attach the old ACL into place, and off you go. You can use a donor graft as well.
Yeah. Commonly, it's from your own leg, though.
Correct.
Yeah.
Yes. So not only are you deficient in the ACL, but you're also deficient in the thing that they take.
Yes.
So you've got to rehab that hamstring or rehab that knee,
Yeah.
that patella tendon. So yeah, surgical. It's arthroscopic these days. It's quite quick. You know,
Yeah.
I think most surgeons get it done in about an hour and a bit, hour and
quite
10
good.
days, and normally you're home the next day.
Yeah.
If not that day. So
Yeah.
a lot of the time it's day surgery, and you're out with crutches and some pain relief. Your knee's going to be really swollen and really sore for about a week.
Yeah, it's not going to be fun.
It's not going to be fun. And often with our surgical rehabs, and we'll talk about the way we rehab those soon, but you're going to be rehabbed to a point where you're actually quite good before surgery.
Yes.
So normally the surgery will result in you being worse, which
Yeah.
is unfortunate, but that only lasts for a couple of weeks. And then you'll be walking again, you'll try and get your full knee range of motion, and then you'll be back
I
to
guess
it.
we think of surgery as, it's just an hour, it's just an hour
Yeah.
and a half, but it's actually, it's quite a big thing for your whole body,
Oh,
not
it's
just the
huge.
knee that
Yeah.
is getting fiddled with.
Exactly, but not only the actual surgery of the knee, but you've got the anaesthetic
Yes.
as well, which
Yeah.
messes up your lungs and all the other tissue in your body. So oxygenation, there could be complications, blood
Yeah,
clots. There's
it's
a lot of risk.
It's a big thing to
Yeah.
go through.
We never want to rush people into surgery. It has to be
No.
their decision.
Yeah.
And I'm not encouraging one way or the other. A lot of people ask me what I would do personally.
Yeah.
And we'll get to that later. But with a surgical review, I've seen so many surgically repaired ACLs.
Yeah.
So many of them are successful and completely
Yeah.
fine. I think in terms of the research, there's no difference between a surgical and a non-surgical ACL recovery after
Right.
2 years.
Okay.
So yes, it's a 12-month rehab, but you still go through remodeling phase and strengthening and things in 2 years, over the 2 years.
Yeah.
And it's not something that we should be rushed into.
No, and I think it also depends on your situation and what you're
Yep.
wanting to, if anything, get back to, I
Sure,
guess. Like if
yeah.
you're wanting to get back to sport, or if you've just loaded an air conditioner into your car and
Yep.
twisted the wrong way.
And I think as well with that, it's not necessarily saying that non-surgical means that you can't get back to those things,
Yeah.
but you need to do a whole lot more work.
Yes.
But still definitely possible. We talked about in the first episode of the knee, the proprioceptive, like you were saying, the input from the ACL itself is massive.
Yeah.
So you get a lot of input to the brain through that ligament, which you no longer have.
Yeah.
And it will take you years and years to build up the new from a surgical graft. So if you don't have that and you don't have the surgery, then you're missing that proprioception. But you can build that in other tissues.
Yeah.
And that's where we come in.
So after you've decided your treatment avenue,
Yep.
what does it kind of look like in the clinic after you've
Yeah.
done
So
that?
deciding surgical, non-surgical, let's say we rule out the Dr. Cross protocol just for
Yeah,
now, because we've already
sorry.
talked about that. So if we go surgical, non-surgical, the first thing is we're going to rehab them both the same way initially.
Yeah.
So I always kind of say to people, even if you want surgery, give it 4 weeks as a minimum so that we can rehab as good as we can get before
Okay.
you go for surgery.
Yeah, right.
That's sort of, there's an asterisk on there, depending on if you've got any other damage, MCL, fractures, what have you. There's heaps of different things that you could do. If you say you've just torn your ACL only, give me 4 weeks in the clinic for getting movement back into the knee, getting you strong back on the knee, because you can function without an ACL.
Yes.
You just need to learn how to do it.
Yeah.
And let's get as strong as we possibly can. I want you kind of feeling that you shouldn't need the surgery if you're going to go through with the surgery, right? Then if you're talking non-surgical, we do the same thing anyway, and we just get going.
Yes.
So in theory, you're going to be much more accelerated than a surgical ACL, ironically.
Yeah.
Because you don't have to deal with the swelling, you don't have to deal with the post-operation sort of ramifications of pain or,
Yes.
the immobility of having a really stiff knee.
Yeah.
So initially, you'll feel a lot better.
Yeah.
And then we load. So what in the clinic, we use what's called the Melbourne ACL Guide.
Yeah.
I think they're up to version 2.0 at the moment. So that's a guide written by Mick Hughes and Dr. Randall Cooper.
Okay, yeah.
So these are our ACL gurus in Australia. And they've put this guide together, and I really, really like it, that it's outcome based.
Okay.
It's got nothing to do with time frames. So back in uni, we were taught, 3 months, minimum 3 months, and they can start running.
Interesting.
So it was always, 3 months and 1 day. Cool, you can
Off
run
you
now
go,
as long as you're
see
paying
ya.
free and you can move, etc. The Melbourne guide is you can run once you pass these tests.
Yeah.
And it's quite a stringent list of things you need to do. So it's in phase 1, it's getting the movement back, getting the
Okay.
range, getting the swelling, getting the physical knee working well.
Right.
Phase 2 is getting that strengthening aspect to it and just loading it up.
Doing it that way instead of as a time-based.
Yep.
It seems a lot more easily applicable to any situation,
Yep.
It's instead of just a blanket.
And it's going to be so variable. You might get back to running in 2 months. You might get in 6 months.
Yeah.
But it's okay.
And that's, it's okay.
It's totally fine. We talk about what you're getting back to as
Yes.
well. Oh, I've got a 9-month deadline. I've got a 12-month deadline. I don't care. It doesn't matter. We talk about those clients and the deadline you have and sort of go, cool, I expect you to be at this level at this time, but I'm not going to rush you. If you're not there,
Yeah.
it doesn't matter.
And we don't know how things are going to go.
Not at all. Yeah.
Right.
And something could happen that means you can't go to the gym for a month. Cool. That means that we're going to have to delay the rehab. So in that sense, we're going to have to change, not necessarily change what we do, but we're going to extend what you do for certain time frames. So it's so individualistic. This is the thing. You cannot put a cookie cutter approach to every injury, even though it's the same injury.
Yeah.
An ACL is an ACL. But the life of that client is so different. And that's why I love this guide, because yes, it's still a step-by-step, but it is so individual that everyone has a different experience with it.
Right.
So we go through the surgical versus non-surgical. By the end of that guide, they're both the same.
Okay.
They look the same. It doesn't matter which one you've had. Again, when we go back to this, when I get asked what's my opinion or what I would do personally, is actually, what would you do? Zoe, you did your ACL tomorrow. God forbid.
God forbid, please.
Touch wood. So you did your ACL. Knowing what you know as a non-clinician,
Yes.
what would you do?
I think I would like to try the cross-bracing protocol.
Cool. Okay. Let's say you weren't a candidate.
I think personally, it's tricky.
It's tricky when you have to answer the question.
It's a tricky one like that, isn't it? Yeah.
Because there are so many factors.
Yeah.
It's just really hard to say. I think in our heads, and it's across the board, that surgery is the fix. Right? We try to stay away from that mindset of going, it's fixing the tissue, but it doesn't fix the problem.
Yeah.
So like a fracture, the surgery might be there to plate the bone back together, but then you've got to start the actual rehab and learn how to use that bone again.
Yeah. I think just thinking about it, I can draw up a pros and cons list for each in my head of,
Yep.
I don't have to have that short-term
Yep.
post-surgery. But then I think of, if I want to play sport and that kind of thing, yes, I can do it without surgery, but at the same time, I don't know what I would do. I'd have to do a lot of thinking, talk to my
Might
friends.
come back in a few episodes.
Talk to
time
my
and answer.
family.
Exactly.
Talk to my physio.
Yep, definitely. So, and this is where you need the team. So Dr.
Yeah.
Cross talked about having the team of 4,
Yeah.
but the team extends so much more in terms of family and friends and experience. Talk to people who have done it. I would say a lot of people, 90% of us would know someone who's gone through it or know someone who has gone through an ACL tear.
Yes, yeah.
And you can get some perspective from them. But
Yeah.
So personally, I'm a tennis player. I dabble in triathlon and, used to play footy, but that is not there anymore. So I would personally go, I'd be okay to try non-surgical as much as I could, even with tennis. And I'm pretty confident personally that I would be able to get back to some form of tennis at a level that I am now, potentially, without a surgery.
Yeah.
Knowing that if I continually, it was unstable or, things weren't happening, then I would be able to go back to the surgery.
Interesting.
But obviously that's going to come with so much work. I'm going to
Yes.
need to be in the gym 4 or 5 days a week. I'm going to need to do a massive amount of motor control exercises and strength exercising and that sort of stuff. So yeah, my life's going to be reorganized like that.
Right. And then when you speak about, being in the gym and that sort of thing, I know just from not personal experience, but just from being around the clinic a lot, you see the people who've had an ACL injury, they'll come in and they'll start off with a physio and then they'll progress into
Yeah.
going to see an exercise
Yeah,
physiologist.
sure. This is the best thing about, well, the gym space we have here in Wollongong is the ability for us to refer straight to exercise physiology when the client has proved that they have pretty full function of their knee.
Yeah.
Walking fine, they can walk up and down stairs pretty well. They might have some swelling still. But really, if they're in that fear phase and they're not getting strength, or they don't even want to go to the gym, cool. That's where we refer on to exercise physiology, and it's a really useful tool
Yeah.
just to accelerate that rehab.
Yeah, I guess they're in a space that is already comfortable, and because
Exactly.
they've come here for physio and
Yep.
they know about
And
what
the
we
EP
do.
coming from a physiological background isn't just going to smash you with reps and sets and
Yeah.
build as quick as possible. They're actually going to take a physiological approach and go through the Melbourne Guide as well, and go through the steps and actually assess and make sure you are able to progress. Or if something is blocking you, then there's nothing to say they can't refer back to the physios and say,
Exactly.
guys, can you just have a look at this for a second? So
Yeah.
that's a really good thing about working so closely with EPs. So that's the guide. I think and we'll obviously talk about it a bit now, the last phase, that sort of phase 4, phase 5 in the Melbourne Guide is the return to sport phase, the exciting phase, the preventative. I hate the word preventative because you can't prevent it. You can
No.
reduce the risk,
Yeah.
but you can't prevent them. So we're going to use that term, hopefully, if I remember. But we're going to try and reduce the risk of future injury, re-tears, that sort of stuff.
Yeah, so I did do some research into the likelihood of a re-tear as well, because I
Yep.
guess just personally,
So this is surgical re-tears.
yeah,
Yep.
surgical, yeah. I mean, personally, I do know a lot of people who've done more than one ACL.
Yep.
And possibly unsurprisingly, I think when I read it, I went, oh, that sort of makes sense, that
Yep.
people are more likely to injure their same knee, so the ipsilateral knee,
Yep.
rather than their other knee, the contralateral. Yeah, I guess around 15 months after surgery compared to 35 months for the other knee.
Yep.
So when you say it, it kind of makes sense because it's
Yep.
a structure that's had to go through a lot of stress already.
Yep.
But another study, it was just males between the ages of, I think, 12 to 19.
Yep.
40% of them, after a 5-year follow-up, had torn another ACL.
Yeah.
So it
wow.
sounds a little bit quite scary and
Yep.
nasty to do, but I think it's something that's important to realize is, okay, if you've sustained it in an environment where there's a lot of possibilities for you to tear an ACL and you want to get back to that, it's like power to you.
Yeah.
But
Even in the surgical world, it's not a guarantee that you're
No.
going to not re-tear it again.
Yeah.
Just because it's been surgically fixed does not make it strong.
No.
And does not make your knee as a whole, and does not make your leg as a whole strong and controlled from a motor perspective.
And I guess an interesting one I found was family history. So the players with ACL injuries in their family were 4 times more likely to injure
Wow.
their other knee. But it didn't affect the risk of the
Yeah.
previously injured knee.
Yeah, I have found that in the clinic. It's anecdotally, it is. You do see it in the family,
Yeah, right.
but it's interesting that you say the other knee. That
Yeah.
it's after their first one, they're more likely to injure their other one because of genetics.
It was
So
very
that's a-
interesting
Yeah,
to
it's cool.
read. It was quite not sad, I guess, to read about, but it was, you never want to hear about people injuring.
Yeah, and you want to never
themselves.
you never want to know that you've got a predisposed risk.
Yes.
I guess to doing this, you never want that hanging over your head when you're playing these sort of sports.
No.
And we never want that as an excuse for people to not play sport. I think this is the dangerous road where we sort of go, well, it's safer for you not to play sport. It definitely is not.
No.
And
Yeah.
there's way worse outcomes if you don't play than tearing, ACLs, even though this is a significant injury.
Yeah, and I think returning to sport is so broad because are you wanting to return to the exact same level
Exactly.
and exact same performance as you were
Yeah.
at before, or
Yeah.
are you happy to do whatever you can, where you can?
And this is where you might need to go, what are my priorities? Well, work is, massive priority. I'm not an elite
Yes.
athlete. I don't get paid for my sport.
Unfortunately.
So, I can still participate in the social aspects of the sport if that's what I like.
Yeah.
Or, I'm going to start a different sport. I'm going to learn something else and I'm going to do, something. We have a lot of marathon runners from ACL injuries.
Yeah.
It's a very common transition, or triathletes and that sort of stuff from a straight line sport.
Yeah.
But there's definitely it's the conversation of going, you're not pigeonholed into one type. You can always sort of shift around, and that's where you need the team to be able to support, and people with a clinical background, but experience is great as well. You need to know sort of, what you're in for. But I think that's super important.
Yeah, I think it's, not just, it's good to have a goal, but possibly realigning the goal of where you're trying to get to.
Yeah.
Like, for example, if I was to do an ACL, I probably wouldn't want to go back to the same level of sport as I have been before, just because...
So is that a fear
I think it's
aspect?
a fear thing, and I think
Yeah.
it's also just from past injuries, knowing the inconvenience of it as well.
Sure. It takes ages, and it might put you out of work, and it, stops you driving and that sort of stuff. I think the mental aspect's a really interesting discussion.
Yeah.
And it's something the Melbourne ACL Guide really does well.
Right.
Because Phase 4 has questionnaires and things that ask sort of about the risk you think you are in about going back to sport, and how likely you think you are to re-tearing ACLs.
And is the, I guess, perceived risk, is that just for going back to sport, or is that with, just walking up the stairs? Or
It could be anything. So
anything.
with the Melbourne Guide is specifically tailored to return to sport,
Yep.
but I use it for people who aren't returning to sport as
Right,
well, and I will
yeah.
change the sport to life performance.
Yeah,
So that's
interesting.
putting the shopping, doing the shopping, walking up the stairs, walking down the
Yeah.
driveway, going for a run for your morning jog. Like, it's those sort of things.
Yeah.
That is life performance rather than sport performance.
And for those that are interested, we'll pop a PDF of
Yep.
the Melbourne Guide.
Yeah,
in
so
the
this
show
is exciting
notes.
because he's released it for free, which is unreal.
That's
so
exciting.
thank you, guys. That's
Thank
really
you,
helpful.
ACL
Thank you, Mick and Randall.
gurus.
But yes, we'll put a link to that PDF on this show, and have a peruse. It's really in depth, and it gives a quick rundown of each phase. But I find people who do sort of not so well on those questionnaires, and to pass this whole thing, you need about 95%.
Right.
Like, that's
a lot.
a lot. You can't fail a lot of these tests.
Right.
And if you fail one, it brings your whole mark down a lot. So you might get to the end, you've done 12 months of rehab and get 87%. And your physio should be saying you need to do more before you return. You are not safe to return to sport.
I think one thing that I find when I'm in a tough situation is having a plan is so good.
Yep.
And to have something there that you can look at and go, okay, well, this is
This is what I'm working
the
towards.
milestones,
Yeah.
I guess. So it's really good that something like that is so easily available.
Yeah, no, it's really useful. And I've been using it for pretty much my whole time in practice. And it has been updated, and it's been, it's been really good. And I've found that it has worked for
That's
my
good.
ACL clients.
Right.
Like, otherwise I wouldn't have used it.
And then I guess in your clinical experience, when have you found it's time to, when you're having those chats, when's it time to not pull the pin, but
Yep.
readjust the pin?
Yeah, it's tricky. Just because everyone's different, everyone's level of healing is different, and the rate of healing is different, people's metabolism is different. It's so difficult to predict where you will be
Yeah.
at certain milestones. The more experience you have as a clinician, the more you will understand those timeframes.
Yeah.
So an experienced clinician should be expecting a client who has ruptured their ACL and has a pretty good rehab to be running at around that 3, 4, 5 month mark.
Yep.
If they're not doing that, or if it's now 7, 8, 9 months and they're just not progressing, we're asking some questions there. And look, that might be on us in terms of programming. That might be on the client in terms of, time availability into the gym, or it might be access to gym or resources. So many variables. And the conversation is going the whole time.
Yeah.
So I'm not one to sort of close my eyes and hope for the best and then wait for 12 months and then say, well, you can't play sport anymore.
Yeah.
I'm communicating with the client the entire way and sort of reassuring them that they're on track, or that, no, we actually need a little bit more push in terms of X, Y, Z.
Yeah.
And hopefully they have the relationship with us to tell us, oh, you're pushing me too hard, or, this program's not right. Because it works both ways too.
Yeah, I'd say you'd probably get pretty comfortable with each other after
Yep.
seeing each other however many times a week
Yeah,
for
it's
months on end.
Exactly. And I think in a place like this, again, when you're using so many team members with the EPs as well as the clinicians, it's a really nice community event. And it actually is, hopefully all of our ACL or clients with ACL tears come in and with a big smile on their face, and we have a great time rehabbing them because they're so used to the place and used to it's actually really fun. So that way, that reduces fear as well. So they know that they've got the right team and they know they're going to get into the right pathway, whatever sort of happens. To go from there. I think our job as clinicians is to identify the risks and to communicate that with the client. To say, look, you are not 100% guaranteed going to be able to come back to this sport. You've got to be okay with that, but we're going to do the best we can. And then you're going to keep reevaluating that sort of month to month. It's a really hard one to go, well, if you're not this by April, you can't play. Yeah,
and I think that's the key thing, is just doing the best that you can. And that's everyone in the team as well.
The thing we can't necessarily modify too much or actually program enough is that mental side. And this is where sort of I really am passionate about getting back to my ACL clients with the mental side of going, I love it when they fail those questionnaires. And that is the thing that stops them returning to sport. Physically, no dramas at all. But if they if they don't reach, I think there's 4 questionnaires on that Melbourne guide. If they don't succeed on those, then they're failing the test because of the way the scoring system works. Then we go back and analyse the actual questionnaire and go through what their fear is and what their mental scenario is happening with them and what their belief is. Because it's often the belief of going, no, I'm going to injure my knee again. There's no way I can play sport. Even though we've rehabbed the knee and physically they're 100%.
Yeah, I guess when you've got that nervous thought in your head, you're going to be doing things differently if they're not fully prepared to go out and play sport. If you let someone go and play sport who's failed the mental questionnaires and they're nervous to get injured the whole time.
Absolutely. That's
our job. You're probably going to get injured.
Exactly. If you believe you're going to get injured, more often than not, you're probably going to get injured purely because you're going to go into the sport with some hesitation and tension. And I can guarantee if it's a contact sport, the person running at you is not.
He's not hesitating.
So they're going at 100% and you're going to come off second best.
Yeah, well, I feel like we could talk about this all day, Ethan.
It's a pretty big topic, isn't it?
It's very big. It's really interesting, though. It's something that...
It's such a common one, especially going into the start of the season this year. So pre-seasons have started and things now. So, hopefully we don't have a huge spike in ACLs this year.
Fingers crossed.
And that the rate keeps going down.
Yeah.
So, I think that will conclude our knee little series for the start of the year.
Yeah.
Thanks so much for listening. And if you've stuck with us through the whole 4 episodes I think we've got now of the knee, go back and listen to some of the other episodes if you haven't got them. Otherwise, as usual, please like and share and follow us on Spotify and follow all our social media on Instagram and Facebook, just to follow what we're up to as a clinic and get in touch if you have any questions. Otherwise, we'll see you next time.
See ya.